Hello, everyone, and welcome to the Obesity Matters Wellness Workshop, where we embark on an incredible journey together towards better health and wellness. Whether this is your first time or you've been with us since the beginning of the session, we are grateful you are here. My name is Rachel, and I am the Vice Chair of Obesity Matters and your host for this year-long program. So today is part 2 of our conversation on anti-obesity medications. By uncovering the facts about these medications, we aim to help you weed out the noise, particularly in social media, and bring you a clearer picture of these medications. What do they do? Who are they meant for? What can we expect? We'd like to welcome back our 2 medical experts from last session, Dr. Megha Poddar and Dr. Jonathan Parker. And to help us dive deeper into this topic, they will be joined by Dr. Florencia Ziemke and Dr. Marsha Novick. All of these doctors specialize in obesity medicine. And like last time, we are bringing you both a Canadian and a US perspective.
As you can see in front of you, we're going to try to answer some of those questions to differentiate between fact and fake. We'll review the summary of the AOMs presented at last session. We're going to go over the goals of treatment, and then we're going to talk about the selection process of medications and what happens after that.
Medical conditions related to weight gain. These include problems like high blood pressure, heart disease, and multiple forms of cancer. And studies show that when we reduce our weight, we also reduce the risk of having medical problems related to the weight as well. Another goal is that we want to physically, emotionally, and spiritually feel better. And studies show that with weight loss, we have an improvement in sleep, we have increased energy levels, we may not need to take as many medications, and there are some studies that show an improvement in self-confidence as well. Besides the patient's perspective of goals, we also have a healthcare provider's perspective of goals as well. And so, of course, we are looking to help the patient with improving their health and trying to reduce medical complications related to the weight. We also want to support our patients in terms of lifestyle changes, and studies show that if we add lifestyle changes plus anti-obesity medications, that combination works better than just using lifestyle intervention or anti-obesity medications alone. And finally, we want to monitor and modify our treatments. So if the treatment is not working, then we want to go back to the table and figure out what is not working and to try to modify our approach.
So what happens now? You've heard about the available medications. Dr. Novick discussed the goals of treatment and the importance of building that patient-provider team. But how do we actually select these medications, these AOMs? So together we get to pick. And for the purposes of this presentation, we created this acronym. Before we get to answer some of your questions, I'd like to explain what factors go into the selection process of a medication. P for preference. Remember, we said the summary that you'll receive is divided into 2 categories, oral and injectable. These are conversations we have on a daily basis with our patients in the office. Is there a preference? Does a patient say, please don't ever give me an injection? I would rather have a pill. P for preference. I is for indication. Yes, these are, the name says it. These are for the indication of the condition of excess weight. We all get that. But as Dr. Novick said, there are over 200 conditions that are associated with this disease. Can we select a medication that is better suited to treat 2 or 3 problems at a time? For example, diabetes, depression. This is the thought process that goes into how we select a medication. And the same thing goes for contraindications. Does a person have a history of glaucoma? Topiramate and phentermine are off the table. Does a patient have a history of seizures? Bupropion is off the table. Again, we get to pick together. And the last 2 kind of go hand in hand, cost and coverage. Is the medication covered by your insurance? If it's covered, does it require a prior authorization, which is basically supporting documentation for its use? If the medication is covered, what is the copayment? If it isn't covered, what is the cost of that medication? And again, most importantly, we get to pick together from the list of available medications.
about the injectables. Is there research or adequate information to know if you max out on an injectable, like sort of a dosage, or are people showing needing increased amount of injections as time goes on?
Obesity is a chronic progressive disease, just like diabetes, for example. So a lot of people feel like after a while of being on medication, it's not working for them anymore. And it's actually not that the medication has stopped working, it's that our obesity has not yet either been adequately or fully treated or has progressed year after year, and now additional therapy is needed. I think a lot of people feel like they should stop the medication at that point, whereas we would certainly recommend not stopping it, but seeking help to see what's next. In terms of dosing, the reason the doses have been chosen is really because of balancing out a risk versus benefit, the benefit of the weight versus the risk of the side effect. And so often with GLP-1s or injectables, the higher the dose, typically the higher rates of nausea and stomach upset that we do see. So currently the maximum dose of semaglutide or Wegovy is 2.4 milligrams. Once you hit that maximum dose, we don't typically recommend going any higher. With liraglutide or Saxenda, it's 3 milligrams. However, it's interesting because they are studying it at much higher doses, 7.2 milligrams. They're studying an oral dose at a higher dose because we know that if you're seeing the right professional, you can actually, get around these side effects if you titrate it slowly. And there are things that we can do to help people that struggle with side effects so that they can get on the right dose of treatment that they need. A lot of people get stuck at the lower doses and then stop because they can't tolerate it, but there are ways that we can help navigate that. So long story short, yes, there are maximum doses that are currently approved by the FDA and Health Canada, and we would typically stop there. But in the next 5 years, I think those doses are actually going to be higher.
I had really good response to Ribelsis, which is the pill form of semaglutide taken daily. And then, upon discussion with my doctor, we switched to Ozempic because we thought it might have an even better response based on the research. And I felt like it did nothing. Of course, it was still working, but I wasn't seeing the weight loss that I saw with taking the pill daily, which was a shock to them because they said I was the first person in the clinic to say that I had a great response from Ribelsis. I'm now feeling a little bit better with Ozempic, taking it twice weekly and the injection in the thigh rather than the tummy. My question to you though, is it possible that I could be a one-off that does do better on Ribelsis because I'm taking it daily for the medication in my system? I'm just wondering, is that a possibility? Like, 'cause I know the research out there for most people, Ozempic is great and it is working. The difference though for me was I felt like my brain got hacked with the daily semaglutide. So I wasn't thinking about food at all. It was great, no cravings. And I have a little bit of that with Ozempic, but not totally. Is it possible I'm like the one-off?
So semaglutide as a molecule, whether it's in an oral form or injectable, is the same. The injectable formulation is slow release over the week, whereas the oral tablet is quick release over the day. So you're not actually getting a different treatment or a different molecule. The difference is that we're able to go to higher doses with the injectable. And so we're able to see greater weight reduction than in the average person with the injectable at 2.4 milligrams versus the oral tablet Ribelsis, which only goes to 14 milligrams at this at the current sort of approved dosing, which is actually less. So the average weight reduction on 14 milligrams of oral semaglutide for the average person is far less than 2.4 of injectable semaglutide. Now, it's interesting that your sort of personal experience has been what it is, because most people, I would say, would benefit more from the injectable. That being said, your story is an important one. So if there's a benefit for you to be on the oral version of semaglutide, you feel that it's improving your symptoms of obesity more effectively, then it's a conversation that I think you should have with your doctor to say that this benefited me more. Maybe the daily version for some reason is maybe you clear out the GLP-1 faster. So maybe the daily version is something that you benefit from, but there's no harm, in my opinion, for you to be on the the oral if it's giving you better benefit. And the other thing I'll sort of say is that they've studied 25 and 50 milligrams of oral semaglutide now, and they're showing the same benefit as the injectable with the oral tablet at that higher dose. So just to sort of say, I would stick with what's working for you as long as it's achieving the outcome that you're hoping to achieve and it's safe, which it sounds like it is. In the future, I think you'll be able to actually get onto the higher doses of oral semaglutide, and that will probably give you the benefit of both those.
Interesting point about that my body may go through the GLP-1 quicker. And I'll just bring up the other thing that my doctor also mentioned was the honeymoon period. Is this a thing?
So, I mean, honeymoon period, my opinion is it's just the initiation of actual obesity medication and obesity treatment, right? So obviously when someone is at a higher weight, has been treatment naive, we're just now initiating a initial therapy. Yes, you're going to have much bigger response if you have not been treated with particular obesity medication in the past. So when you initially start treatment and you're making GLP-1 and then we're giving you GLP-1, you're going to have, an initial response. Over time, part of what may be happening with your not responding to Ozempic as well now is, as Megha pointed out, it's now more dose dependent than it is a molecular structural thing. You're now making less GLP-1. Your metabolism is actually going to be slower because you've already started to lose weight. So you're in a situation where now your body has pushed back, and we call this metabolic adaptation, where now your metabolism's lower. You're not making as much GLP-1. You're a little bit hungrier. So one of the reasons why it's dosed higher and why semaglutide is dosed at a higher dosing than even a milligram or even 2 milligrams is because we have to be able to continue to treat the adaptation that happens with your body trying to drive your weight back. So, everybody's different. Everybody needs to have their own particular personalized treatment, and there's nothing wrong with oral versus, injectable, but have that conversation. But from a mechanistic standpoint, some of that is where you are, how much weight you've lost, how much GLP-1 you're making, your body's ability to regain that weight as to what your response is.
Like to piggyback on what Jonathan had said as well. And no matter which medication, all of the studies show that there are some people that respond to the medication, and then there are others that don't respond at all or even gain weight while taking the medicines. So everybody responds differently. If the medication and the treatment is not going well, then it's important to go back to your healthcare professional to say, hey, this is not working, or I'm having lots of side effects to the medication. That gives us an opportunity to reevaluate. We shouldn't be blaming ourselves that we didn't respond to the medication, but we may need a higher dose. We may need a different medication, or even to stop the medicine that has been the first choice.
Asked a question about what the best time to start an AOM is, and Megha has responded to that, and Suzanne has, so you can check in the chat. Suzanne then followed with a question about, are there any medications that prevent obesity?
That's a good one.
Yeah, I love that question because it means that we're all thinking. It tells me that I think we're getting the messaging across about how these medications work and why they're so important. The short answer right now is no, because right now, in order to qualify or test these medications or see what we're trying to accomplish, we're looking at those who already have obesity. The pediatric population is a really interesting one because there is, lots of conversations about treating early. Like, should we be waiting till adulthood? Should we be waiting till puberty or high risk time periods where we know individuals can gain a lot of weight before we actually offer treatment? I don't think that we have the answers yet to say, can we do the risks outweigh the benefits in prevention, especially with medications, right? Because it is still a medication. We know that medications offer benefits to improving blood pressure, cardiovascular risk, and now even mortality or life, but that's only in people living with obesity already. So I don't think we have the answer yet to say that, a medication is going to be specifically recommended for prevention. However, behavioral modification and lifestyle modification is where I think that treatment can really shine. Because if you're supported with the right person and you feel like you're at risk of obesity because of your genetics, or perhaps having symptoms around relationship with food, increased hunger, but don't yet have obesity, as a sort of disease disease established already, then working through models about understanding your relationship with food, understanding hunger cues or craving triggers or those kind of behavior challenges may actually be more effective in the prevention stage than the actual obesity treatment stage, because we know those who live with obesity, they have higher rates of appetite dysregulation or higher rates of cravings and having difficulty with certain behavior changes, which is why medications are so effective for that population compared to treatment. So, I don't have a perfect answer for that, but right now I would say most of us aren't able to support through medications for prevention.
Some other people were commenting on in the chat and asking questions rather about the contraindications of the drugs over the long period of time. And there's been news reports and such on the thyroid cancers. And I'm concerned about that because I've had cancer before and I'm living with lupus now. And now I've been on Saxenda for over a year, probably a year and a half. And so it is something that I am really wanting to know what the doctors have to say about it, because I don't often have the opportunity to be able to talk to my GP.
Specifically in the trials, this is for medullary thyroid cancer, not follicular or papillary thyroid cancer, right? So it's a very specific kind of cancer, which is already a very low incidence of cancer generally when it comes to your thyroid, right? So we also know that rats have different thyroid glands. So the model is a little bit difficult when you're trying to compare apples to apples from a risk standpoint, because it's a kind of a poor animal model. So what we know from the studies are, yes, there seems to be rat data that shows that there's an increased risk for medullary thyroid cancer. The contraindication currently is just a history of medullary thyroid cancer. Obesity drastically increases cancer risk, right? So we have 13 kinds of cancers that are associated with obesity, particularly GI and GU cancers. I mean, breast cancer recurrence is 25-30% higher. Can't remember the exact number in someone who actually also has obesity as a disease state. And so it's important to remember that when we're treating obesity, we're also decreasing cancer risk. Even with a bariatric surgery study recently about reduced incidence of cancer in post-bariatric surgery patients, because adipose tissue and fat is not just some blob that sits there. It is an active organ. It's constantly secreting adiponectins and inflammatory markers and all this other junk that causes significant changes at the cellular level from an inflammatory standpoint and from a DNA altering standpoint. So treating obesity reduces your risk for cancer overall. And I think that that's important to remember as we think about the risk for thyroid cancer with GLP-1 agonists.
Thank you so much to all of our panelists, Florencia, Marsha, Jonathan, and Megha. We really, really appreciate you helping us navigate this really difficult topic that has a lot of noise in social media. And so it's really good to be able to get down to the facts to help us make a decision if this is something we should be considering in our journey.